بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا مولانا محمد وعلى آله وصحبه أجمعين. Again with you with another important aspect of growth and development. This is the normal and abnormal development. We discussed before the different aspects of growth, and we discussed before what is the difference between growth and development. Let us remind you again from the early beginning, from the life journey. We have started from the zygote with multiple mitotic divisions to form billions of cells, and this was called growth. Once the group of cells are grouped together to have a certain function, this is the development. And as you remember, we said before, the growth and development go sequentially, go hand to hand together, not preceding each one. Growth does not precede development, and development does not precede growth. This is an important point to know. So growth means increasing the size of the organism due to increasing the size and number of its constituent cells, but development means acquisition of skills. Okay? Again, as we started before, this is a pre-test to check your concept about development this time. Please read the questions, answer the questions, and keep the answer in your mind to re-answer it again after the lecture. The first question, growth usually precedes development. Yes or no? The second one, developmental delay cause growth failure. Yes or no? The third one, developmental delay equal mental retardation. Yes or no? Failure to thrive means developmental delay. Yes or no? Delayed speech usually diagnosed at the first year. Yes or no? Rickets leads to growth failure. Yes or no? Malnutrition affecting growth and development. Yes or no? Keep the answer in your minds after the lectures. The objective of this presentation is definition, domains or the aspects of development, as we said in the previous lecture, and discussing the abnormal development is the developmental delay. So again, this is the definition as we discussed before. Growth and developments go hand in hand together, and the development is acquisition of skills and maturations of the already formed organs by the growth. Important points and important aspects to know that the development is a continuous process from conception to maturity. Another important point that the development run cephalocaudal. So the patient has to have head support before sitting and sitting before standing. The patient or the infant does not stand up before sitting, does not sit down before head support. The development and developmental aspects run cephalocaudal. This is a very important point to know. Again, these are the domains for the development. Do you remember the domains we mentioned for the growth? It was also the same picture. 4 main items. So these are the domains, these are the aspects, these are the items of development. Again, this is an important figure to answer the parents' questions. Does my child develop normally or does my child develop poorly? To answer these questions, I have to check all these domains. The first one we are going to check is the gross and fine motor development. This is the motor development. Then the mental development. Mental development including educational, speech, and psychosocial. And we have to check the vision and the hearing. If we checked all these items, all these domains, I can say to you, this is a normal development or this is an abnormal development. So I have to go first for the gross motor development. This figure is a simple figure to remind you about the different stages of the growth motor. The first one is the head support. The infant usually supports his head in the neutral position around the age of 3 months. Sitting alone. Sitting with support usually starts at the age of 6 months. Sitting alone from 6 to 8 months. Crawling usually at the age of 9 months. Standing up at the age of 12 months. Walking at the age of 15 months. Running at the age of 18 months. Going upstairs usually 21 and going downstairs usually at 24. So this is the rule of 3 to remember the items of the gross motor development. Head support, again, I remind you, the gross motor and the other aspects of development run cephalocaudal. If the patient has delayed head support, for sure, there is delayed sitting, delayed crawling, delayed standing, delayed walking, and so on. So this is the head support will start around, will complete around the 3 months of age. Okay. Regarding this figure, crawling is not necessarily to occur. Not all infants crawl. Who are crawling? Those who gave the chance to crawl. If the infant does not have the chance to be put on the grounds to crawl, he will not do. But he will sit down, then he will start standing and walking and so on. Another important point we see, all of us know that going upstairs is more difficult than going downstairs. However, the infant going upstairs first before going downstairs. Why? Because of safety. Because going upstairs is more safe for the infant than going downstairs. So don't surprise about going up first before going down. He's doing the safest issues before than the easiest issues. This is the gross motor. This is an important figure to understand what is the rationale behind this. What do we need to sit down? For the infant to start sitting down, all of us have infants. The infant may come down in the front, may fall on one side, may fall on the other side, may fall on the back before deciding to sit down properly. What happened? To sit down, I have to have normal CNS, normal musculoskeletal system, and good systemic environment for the brain and for the musculoskeletal system to work in. So the brain will start contraction of the abdominal muscles only. This led the child to fall forward. Sorry. Start to sit down again. Let the back muscle to contract only. So the patient fall backward. This is the brain or talking to the patient, to the infant. Then contracted the oblique abdominal muscle to the left, fall to the left side, and another to the right, So the brain get the information to sit down properly. I have to contract the abdominal muscles, the back muscles, and the oblique muscles of the abdomen. So I can sit down alone. So I have to have a good CNS, good mentality, good assessment from the central point of view, then a good musculoskeletal system, and a good systemic environment for those to act. This is an important issue because if I'm going to say this patient has delayed gross motor development, so the problem, where is the problem? Could be in the CNS, could be in the musculoskeletal system, could be in the systemic environment. But before deciding this is the normal figures as we have. When I consider this infant delayed regarding this issue, delayed growth motor, look at the other figure. Before looking at the other figure, we will see some pictures for the normal growth. What is this? This is pull to sit test to check for the head support. You notice that the head is in the line with the shoulders. So this patient supporting his head. So this patient's around the 3 months of age. This is head support. This is pull to sit test, you see? And the head at the same line of the shoulder. This is also head support. This is more head support. You see, the head becoming acute angle with the chest. So this patient's older than 3 months of age. Look at this, the patient in the prone position, and this is head support. Look at this. This is the patient is sitting alone. So what the expected age for this patient is 6 to 8 months. This is important. This one, again, the prone position with full head support. This one, crawling. So what the expected age for this? By the mnemonics we have said before, this is around 9 months of age. Remember, head support at 3, sitting alone 6 to 8, crawling 9, standing 12, and continue by the number of 3. So this patient, usually, or this infant, usually at 9 months of age. This one, try to stand up. So he's more than 9 months, but less than 1 year. This one is standing, so 11 to 12 months of age. Again, this is the normal regarding gross motor. What's abnormal gross motor? When I consider this infant has delayed locomotor development, we said before, the head support usually occur around the age of 3 months, full head support. If the patient does not support his head up to the age of 4 months, delayed or not? Up to the age of 5 months, delayed or not? So I have cutoff points. The head support, we will remind this also by the number 5. If there is no head support till the age of 5 months, this is delayed. If there is no sitting alone till the age of 10 months, this is delayed. If there is no standing till 15 months, this is delayed. If there is no walking till 18 months, this is delayed. This is an important point to target who is delayed, to further investigate for the causes behind this. So you have to know the normal, but this is not enough. To know what is the range, the normal range, when we consider this abnormal. Regarding the gross motor, we remembered the number 3 from going up to down, cephalo-caudal. And we give us a chance. The head support around 3 months. Give him a chance till 5 months. If no head support till 5 months, this is delayed. Sitting with support at 6 months and without support at 6 to 8 months. We give him a chance till 10 months of age. Crawling, 9 months. Standing at 12 months. We give him a chance till 15 months of age. Walking, usually start at 15 months. We give him a chance till 18 months of age. So if a mother came to you, said that my infant does not walk. How old is he? He is 12 months old. So this considered as delayed walking? No. Till here, we consider delayed walking when there's 18 months of age without walking. Try to help him. Try to train him. This is an important point. She will tell you that my sister, the infant of my sister is walking at 11 months, at 12 months. This is not true. These are the rules. The patient considered as delayed walking if reach 18 months of age without walking. Okay, this is regarding the gross motor. Now again, if the patient has delayed walking, so what are the causes behind this? Delayed locomotor development. As we said before, for the normal development, for the normal gross motor, we have to have intact CNS, musculoskeletal system intact, and a good systemic environment for those systems to work in. So if the patient has delayed locomotor development, no head support, again I remind you, no head support till 5 months of age, no sitting alone till 10 months of age, no standing till 15 months of age, no walking till 18 months of age, then he is delayed. What are the causes behind this? Only these are the 3 main areas to look for. Either the brain, maybe mentally retarded, maybe cerebral palsy, the commonest, maybe musculoskeletal system problem, brackets or malnutrition, maybe chronic systemic defects, chronic renal failure, chronic liver failure, chronic pulmonary disorders, heart failure, congenital heart disease, something like that. So the first point is the gross motor, which is normal and which is abnormal, when we consider it abnormal. And if we consider it abnormal, what are the causes behind this? If I classified it like that, it is easy to pick it up. Another point, remember, this is the mainstay for this lecture. These are the domains of the development. These are the items of assessing the development. This is the development. Here, do you remember? This is the gross motor. This in yellow, this is the normal one. You see the stations? And this in red, this is the abnormal one. This is the rule of 3, and this is the rule of 5. Do you remember? And these are this CNS. This area, musculoskeletal system, and this area, the systemic environment. So this part is to know which is normal, which is abnormal, what are the causes behind these abnormalities. Again, we will go to another area, fine motor development. We're still in the motor development. We said gross motors, using large muscles, large striated muscles. Now we are going to the fine motor development. We have different stations for the fine motor developments. Usually, at the age of 6 months, the patient transfer object from hand to hand and put it in the mouth, mouthing. This is important point. At 12 months of age, there is what's called pincer grip or pincer grasp. The infant can pick up objects by his fingers, by his index and thumb fingers. Once he can do this, he can drink from 2 ear cups. He can play peekaboo. He can hold 2 objects, 1 in each hand. So this will occur at the age of 12 months usually. At the age of 18 months, the infant have more fine motor development. He can do what's called scribble using the pen, okay, and can turn pages and try to feed himself. After that, he can build up a tower of 3 blocks. So at that age, the patient scribble, try to feed himself by cup and spoon. At the age of 24 months, around the age of 2 years, he can build up a tower of 6 blocks and can start drawing 2 lines. Before, he was a scribble, doing haphazard lines. But at the age of 2 years, he started to draw 2 lines as a preliminary to draw a triangle, to draw a circle, to draw a rectangle. Okay, this is the fine motor. These are the important points of the fine motors. It's easy to remember. The first one at 6 months. Yes, this is logic. Catch objects by his hand, transfer it from hand to hand, and try mouthing. At the age of 12 months, do you remember? By pincer grip or pincer grasp. And all other activities using these fingers. At 18 months, scribble, try to feed himself. And at 24 months, try to draw lines. This is sufficient for the fine motor development at the general pediatrician. So again, the motor development, including a gross motor and fine motor. Where is the development in the domains? Development is again back to the mainstay, the main figure. Development, this is the motor. They are mental, some hearing and vision. So this is the motor gross and the fine motor. Gross motor, do you remember? The rule of 3 and the rule of 5 to be abnormal. The fine motor, do you remember? At 6 months, then at 12 months, then at 18 months, then at 2 years. Okay? So we will come again to the mental development. The first item for the mental development is the speech. Speech development. Usually the patients at the age of 2 months doing a cooing sounds, vocalizations. He divert your attention that there's somebody here. At the end of the first year, he says words, only separate words. Maximum 10 words, but usually 2 words beside mama and dada. This is at the age of 12 months. It is easy also to remember. Only cooing sound, yes, I'm here. And at the age of the 1 year, he said words only, separate words. At the age of 18 months, the next station, he can build up a sentence of 2 words. After that, he can build up a sentence of 3 words. So at 18 months of age, he has 2-word sentence. And he can point to the body part. This is nose. Okay? At the age of 2 years, 24 months, he can form 3-word sentence, and he also can count to 100. At 36 months, he has to know his full name, and at 5 years, he had to know his full address. Easy to remember. Up to the first year of age, he says words only. 1.5 years, 2-word sentence. He uses these words to form a very simple sentence. At the age of 2 years, more complex sentence, 3-word sentence. After that, he can know his name, his full name. After that, he can know his full address. This is important. And for the speech, for the infant to speak or to talk, what do he need? He needs, first of all, to hear, then to understand, then to vocalize the words. So, simply speaking, if the infant did not speak, what were the problem? Either the first one, we have to check hearing. The second one, mentality. The third one, vocalization, the articulation of the words. So this is the idea behind the speech. We'll come to this later. Another area for the development, which is an important area, what's called psychosocial development. Psychosocial development is a very important area. We have these items: social smile. Social smile usually occur at the age of 40 days. What's social smile? We can have the question by another way. What are the physiological smiles we have? For sure, we have a pathological smiles and pathological cry and pathological laugh and pathological sounds. What are the physiological smile we have? We have what's called angel smile. The patient or the infant is smiling while he's sleeping. It has no importance for us. Social smile, the infant smile to anything moving around him, which is very important because this is the earliest indication of the cerebral function. And then recognition smile, which usually around the age of 9 months, he smile to whom he knows and cry for the strangers. So the social smile is very important. He smile every now and then for every moving object, whatever. And this social smile usually start around the age of 40 days, after about 6 weeks of life. Very important date. Then laughing with a voice, usually around 2 months, important also, as we will see after. Mother recognition, usually around the 4 months, then father recognition, usually around the 9 months. These parameters, these items, it depends on who is giving the patient, giving the care to the infant. Suppose this is the dada, so we can say this dada recognition. Suppose the father is the one who gave him the care, so this is the father recognition. So this is variable according who is giving him the care. Speech, as we said before, remember, at the age of the first year, words only. Maximum 10 words. 1.5 years, articulate simple sentence, 2-word sentence. At 2 years, 3-word sentence. This is important. So we'll come to discuss it in a different way, according to the age. As the parents come to you, my infant is 6 weeks old. What parameters he has to do? What in the gross motor and fine motor? What about the speech? What about the psychosocial development? For 6 weeks old infant, he can do gross motor. Which items of gross motor he can do? He may support his head, supporting his head, usually completed at the age of 3 months, and ventral suspension with prone position. Fine motor, he can stairs and follow horizontally, follow the object horizontally. Don't worry about this. You don't have to remember this. I will give you, after few minutes, the red flags for abnormalities, red flags for cognitive dysfunction, red flags for developmental delay. But I should know, at the 6 weeks of age, there are warning signs. If there is no visual fixation, if the infant does not respond to the sounds. So in the first 6 weeks of life, hearing and vision carrying the most important items. Does not respond to the sounds, does not fixate visual fixation. This is important. And another area, the primitive reflexes is abnormal, asymmetrical primitive reflexes, or there is head lag. This is for the 6 weeks. The main block, 6 months, 12, as we said before, we usually doing the developmental assessment through main blocks. The main blocks are at 6 months of age, at 12 months of age, at 18 months of age, at 2 years, and going at 3, 4, 5, and 6 years after that. So come to the first block, the first main block, at the 6 months of age. Do you remember the gross motor? Oh yes, the head support at 3 months. Sitting with support at 6 months. So suppose this infant at 6 months of age, supporting his head and sitting with support. What about the fine motor? Oh, do you remember? Yes, at 6 months he can transfer object from hand to hand and start mouthing. Now, what about speech? Vocalize and say some words. You may say mama and dad. Social behavior, mouthing and social smile. Smiling at 6 weeks, which is an important issue. What are the warning signs? The warning signs at that age, hand preference. The infant usually does not have hand preference until the age of 2 years. If he prefers to use one hand before that age, this may suggest cerebral palsy. Why? Because if the infant prefers to use the right hand at 6 months of age, what does it mean? It means that the left hand, there is a pathology in the left hand. He cannot control his left hand properly. So hand preference before 2 years of age, mostly it is pathological. If I found the infant at 6 months of age, usually using one hand, this is abnormal. Fisting means cortical dysfunction. Squint, or persistence of neonatal reflexes. These are the warning signs. You should know about this. Another block. At the 12 months of age, do you remember the growth motor? Yes, the rules of 3. At 12 months of age, you can stand up. Nice. Now, regarding the fine motor, yes, at 12 months of age, pincer grasp, holding 2 objects, playing peekaboo, drink from 2 ear cups. Remember, these all activities could be done by fingers only. What about the hearing? He can turn to sounds, and social behavior, he can drink and wave bye-bye. 18 months of age, the important point to remember is the fine motor is scribble and turn pages, as you remember, and the gross motor, we know, but 18 months of age, he was walking and even start running. Speech, at 18 months, he say 2-word sentence. This is reminding of what we said before. Social, he can hold the spoon, try to feed himself, as we said before in the fine motor. At the 24 months of age, he can climb the stairs, try to descending stairs, pick up hundreds and draw lines, so whether vertical or horizontal lines. This figure representing some of the primitive reflexes and equilibrium response. We'll not go deep through this, will be discussed later in the neonatal examinations, but they are important issues to assess the development, as we will see after a few minutes. How to assess the mentality of your infant. The primitive reflexes will play an important role. What is this? This is the example of the Moro reflex. This is parachute reflex. This is asymmetric tonic neck reflex. And then we will come after we discuss the different aspects of, or different domains of the development. I remind you again, motor, which is gross and fine motor, mental, mainly regarding the speech and psychosocial development, then vision and hearing. What is the abnormal? Developmental delay. When we consider the child delayed or the infant delayed, there is global developmental delay and specific developmental delay. What's meant by global developmental delay? Global delay, there is delay in 2 or more aspects of the development. Specific delay, delay in 1 aspect of the developmental milestones, as we will see now. So, for example, to remind you, this is the gross motor development. We remember that the rule of 3, this is the normal, and the rule of 5, this is the abnormal. No head support till the age of 5, abnormal. No sitting till the age of 10. No standing till the age of 15, walking till the age of 18. So this is delayed locomotor development. If the infant only have this problem, so this is a specific developmental delay. If the infant has delayed gross motor and delayed speech, for example, this is a global developmental delay. If the patient has problem in the psychosocial development, in the speech, in the gross motor, in the fine motor, this is definitely a global developmental delay. So this is an example of a specific delay. The only problem was here, but the patient can speak at the proper time. Psychosocial development is okay. Mentality was okay. So this is specific developmental delay affecting only the growth motor. And the frank example of this is the rickets. So back to the question, rickets affecting the development rather than the growth. This is the development, and affecting which aspect of development? The gross motor development. Because delayed sitting, delayed standing, delayed walking. But what about the growth? Nothing about the growth. He eat, he gain weight, he increase in the size, but the only problem he have, he cannot do the growth motor development. To remind you again, causes of delayed motor development, this is either CNS disorders, mental retardation or cerebral palsy, musculoskeletal system involvement, rickets or malnutrition, or chronic systemic environment. This is an example for a specific developmental delay. Another example for a specific developmental delay, the delayed speech, as we said before. Once the infant, when we consider the infant had delayed speech, if he reached the 18 months age without talking any words, this is considered delayed. And if we consider him delayed speech, which areas to assess? The first one is hearing. We have to assess hearing. As we said before, he has to hear, then understand, then articulate. So if there is no speech at the proper time, 18 months of age without saying any words, this is delayed. So this one, I have to check first hearing, then mental state, if he's mentally retarded or not, then there is articulation defects maybe. If the patients have only delayed speech, this is specific developmental delay. If the patient has only gross motor defect, this is a specific developmental delay. If the patients have more than 2 domains affected, this is global developmental delay. The global developmental delay, we will talk about what's called mental retardation, which is synonymous to the global developmental delay. Before the age of 5 years, global developmental delay equal to mental retardation. And usually you are using this term. After the age of 5 years, the term usually used is mental retardation. Mental retardation or global developmental delay, more than 2 aspects affected, usually the brain is involved because the brain is the maestro controlling the developmental items. If more than 2 aspects are affected, usually we look at the brain. There is a problem in the CNS usually. What is the problem? Maybe intellectual problem, maybe adaptive problem. Intellectual problem, the higher functions is affected regarding reading, writing, language, learning. Maybe the adaptive mental retardation, maybe the lower functions also affected. Eating, dressing, toilet training, which reflecting the severest form of mental retardation. So again, another important question, when we consider how to assess mentality of our infants and children, this is the questions usually asked by the parents. If you have a newborn infant, how can I check for mentality? In the neonatal period, I can check for mentality. I can have an idea for mentality through the primitive reflexes. Suppose the newborn infant has a brisk motor reflex. There is something wrong with the CNS. Suppose a newborn infant has depressed the motor reflex. There is something wrong with the CNS. So it may give an idea in the neonatal period. In infancy, how can I assess the mentality? In infancy, usually you assess the mentality by the psychosocial development. How come? We will see. If there is no social smile till the 3rd month of age, this is delayed, and we have to suspect mental subnormality. Remember again, social smile is an important issue reflecting the cortical functions, and it usually starts around 6 weeks, around 40 days. We give a range till 3 months of age. No social smile after 3 months of age, this is abnormal. No loving till 6 months of age, this is abnormal. Remember, the infant usually love at 2 months of age, love loudly. No mother recognition till 9 months of age, this is abnormal. This abnormal psychosocial development reflects mental subnormality in infancy. In preschool children, I can assess mentality through speech, through talking with the infant or talking with the child. If there is no speech till 18 months of age, this is delayed speech. And they can assess the mentality by talking to him. You should know about his name, know about his place, should be oriented about the surroundings. In the school age, I can assess mentality through IQ and the school performance. So I can have an idea about the mentality in different age groups. You see here, early, the psychosocial development is the most important. Later on, the speech is the most important. Later on, the school performance and intellectual functions regarding learning, reading, writing, and language. This figure and this slide for the parents, these are the features indicating cognitive problems. How can I suspect my infant or my child have a cognitive problems? It is easy also to remember. Before the age of 6 months, if the infant is not alert, this is abnormal. The infant should be alert in the first 6 months of life. At 6 months of age, if the infant is not interested for the dropped object, this is considered abnormal. At the age of 12 months, at the age of the first year, the infant should be interested for the hidden object. If he's not interested, this is abnormal. Between 6 and the 12 months of age, the patient or the infant usually play peekaboo. If he does not, this is may considered abnormal. So the clocks before 6 months should be alert. If not, this is red flag for the parents. At 6 months, not interested for the dropped objects. Can these objects and drop it down, which is not interested. Even he didn't look at it. This is abnormal. At 12 months of age, if the infant is not interested for the hidden object, he doesn't look at the hidden objects, this is abnormal. At 2 years of age, the infant should know the similarities. Those are cars, those are camels, those are animals, those are books, those are papers, those are pens, and so on. If he is not interested in the similarities at 2 months of age, this is red flag for the parents. At the 3 years of age, he should know his name. If he does not, this is abnormal. At 4 years of age, he can count sequentially. Whatever, count to 100 to 10, but should count sequentially at 4 years of age. If he does not, this is abnormal. This reflects a cognitive problem. At the age of 5 years, if the patient does not identify color, this is abnormal. And at the age of 6 years, if he doesn't know his birthday or address. However, at the 6 years, a lot of children does not know their birthday or address up till now. And this depends on the locality and depends on the culture. So this figure, again, this slide for the parents to pick up, oh, there are abnormalities. I think my infant or my child is not normal. How could you assess this? According to the different ages. Should be picked up by the parents and picked up by the general practitioner or the family physician. This slide for the physicians. How to assess the developmental delay? What are the warning signs for the global developmental delay? If there is family history of mental retardation, family history of cataract, family history of deafness, I have to suspect. If there is maternal concerns about their infant or child, this is important. If there is dribbling, if there is persistent squint, if there is persistence of neonatal reflexes beyond the age of disappearance, if there is regression of developmental milestones, all these items should be taken up seriously, because this may reflect global developmental delay and mental subnormalities. Is it important to pick up those children and infants? Yes. What will you do for them? I will investigate. And there are some preventable causes of mental retardation could be prevented. Not only for diagnosis, to target this infant or this child, this is mental retarded individual. So what will you do for him? As we will see after. So mental retardation, fortunately, the cause of mental retardation, 10% only organic causes, including genetic and non-genetic, and 90% subcultural, depend on the environment, depend on the learning, depend on the training, depend on the communications with others. This is fortunately. This table is an example for the causes of global developmental delay. As we said before, global developmental delay equal mental retardation. But we use this term before the age of 5 years. There are prenatal causes, perinatal causes, and postnatal causes. The causes are variable between genetics, metabolic, congenital infections, asphyxia, metabolic disorders, general infections, and etc. This is examples for the cause of global developmental delay, which is a lot of causes. The effect may be starting in the prenatal period, deranging the brain and its function, or in the perinatal period or the immediate postnatal period. Here is the list of common causes of global developmental delay. Prematurity is the cause. Constitutional and the familial causes. Yes, it seems logic and makes sense. Deprivation, important issue. Maternal deprivation is an important cause of mental retardation. And again, the cause of mental retardation, 10% only are organic and 90% are subcultural. And the maternal deprivation is one of the important items. If there is specific abnormalities or autistic disorders, this will give rise to global developmental delays. Again, if we labeled an infant or a child with global developmental delay, are all the same? No, there are degrees. There are mental retardation, can cope with activities. Another one with mental retardation cannot. So there are degrees of mental retardations according to the IQ. Either mild mental retardation, if the IQ vary from 70 to 51, this one considered the mild form of mental retardation. What does it mean? And this infant is educable. We can educate him in certain schools. If the IQ from 50 to 36, this is considered as moderate mental retardation. What does it mean? This infant is not educable, but trainable. I can train him for certain jobs and certain activities. If the IQ is from 35 to 20, this is severe form of mental retardation. He is not educable, he is not trainable, but he can do minimal self-care. If the IQ below 20, this is a profound mental retardation. This is total supervision. Cannot do anything for him. Need somebody else to help him eating, drinking, toilet training, and so on. But there are abnormal points to be considered, may be confused with mental retardation. Such conditions: abnormal vision in infancy, abnormal hearing in the preschool age, attention deficit disorders in the school age. This may cause mental retardation, and this is one of the preventable causes of mental retardation. Suppose to interact with the surroundings. I have, logically speaking, I have to see all around me, all surrounding me, and I have to hear who are talking to me to proper interact. If I'm not hearing, so the interaction will be affected. If I cannot see, the interaction will be affected. If I have a concentration problem, severe chronic deficiency anemias, for example, attention deficit, so the interaction will be affected. So the brain needs a training every now and then. Training, like the muscle. Training of the brain is hearing, vision, thinking, interaction, speaking. This is very important for the brain to continue its activity. Okay, so before diagnosing mental retardation, I have to make sure that the infant had a normal vision, a normal hearing, a normal concentration span. This example for how to assess the IQ or how to categorize the IQ results, the IQ scores. For example, the normal range for the IQ score, the score from 90 to 109, this is average. If from 110 to 120, near 120, this is high average. These are the terms. I discuss it here because there is no place for the genius. Either the average, more he is high average, more he is superior, more he is very superior. These are the terms, the scientific terms. Genius is not a scientific term regarding the IQ score. The patient low, this is the average from 90 to 109. If it is from 80 to 89, this is low average. 70 to 79, this is borderline. And then the other classification, as we said before, mild mental retardation or severe, moderate to severe, and profound. Only this slide to ensure that either very superior or profound mental retardation. No place for genius and more superior individuals. To diagnose mental retardation, again, we use the mental retardation as a synonymous for the global developmental delay. Global developmental delay, 2 or more aspects of the developments are affected. And if 2 or more aspects of the developmental domains or developmental milestones are affected, this will reflect mostly the CNS dysfunction. And what is the most important cause for this dysfunction? We discussed some examples. Maybe the cause may be prenatal, perinatal, or postnatal. And we discussed the degree of mental retardation. How can we suspect this infant is mentally retarded? Usually from the history, as we said before, clinical pictures, odd-looking features could suspect underlying chromosomal disorders or congenital anomalies. And most of the congenital anomalies and the chromosomal disorders have mental changes, mental subnormalities. I have to examine also the eye. If I find a cataract, may reflect a disease with mental retardation. I have to examine the heart. If there is congenital heart disease, may be combined with mental disorder, mental subnormalities. Head examination is important, and hepatosplenomegaly for metabolic diseases. Lab screening is a very important point to talk about, because we are talking about mental retardation, trying to prevent the causes of mental retardation. Try to pick it early. For example, one of the most important preventable cause of mental retardation is hypothyroidism. Again, if the patient was diagnosed as having hypothyroidism at the age of 6 months, he lost about 50% of his mentality. If he is diagnosed as hypothyroidism at the age of the 1 year, he lost about 75% of his mentality. If he diagnosed near the age of 2 years as has hypothyroidism, he lost about 80 to 90% of his mentality forever. So such disorders I have to pick up early before mental derangement. That's why it is one of the most important screening tests in the neonatal period. Each newborn should be screened for the thyroid function. If there is hypothyroidism, I have to treat it early. A lot of screening tests in the newborn, will be discussed later in other areas, but one of the most important is the hypothyroidism. Other metabolic disorders, some metabolic disorders could be prevented easily. Phenylketonuria, galactosemia, fructosemia could be prevented easily if I picked it up early. Simply, I can use a simple formula, a specific formula to prevent this mental retardation. So it is not nice to diagnose this patient have severe mental retardation, but it is more nice to prevent, to know the causes of mental retardation, to anticipate the mental status of this individual and try to interfere to prevent or to decrease the degree of mental retardation. Yeah. This infant, this is the prone position, put in the prone position, ventral suspension. This has an apathetic look, suspecting mental subnormality and the generalized spasticity. It is the same infant. You see the lower limb is spastic and the patient have an apathetic look. There's motor changes and mental changes. See, not interested in the surrounding, scissoring of the lower limb, foot drop. Back again to the pre-test. Growth usually precedes development. Is it right? No. We said before, growth and development go hand in hand together, go simultaneously from conception till maturity. Developmental delay cause growth failure? No. There is a separate line between developmental delay and the growth failure. Growth failure means the weight is underweight or the length is short. But developmental delay means activities. So the patient may have developmental delay, but regarding the growth parameters are okay. He's good regarding the weight, good regarding the height, but he cannot do some activities. He cannot speak. He cannot sit down properly at the time. So there are differences between developmental delay and the growth failure. Developmental delay equal mental retardation? No. What's equal mental retardation? Global developmental delay. Of 2 or more aspects of the developmental milestones are affected. But if one aspect is affected, this is not mental retardation. Examples, delayed speech only. This is specific developmental delay, not mental retardation, not specifically mental retardation. Delayed gross motor development. Patient has rickets, has malnutrition. Not necessarily to have mental retardation. This is a specific developmental delay. So mental retardations means a global developmental delay, means 2 or more aspects of developmental milestones are affected. Failure to thrive means developmental delay. No. Failure to thrive is a problem with the weight or the height. But developmental delay is the problem with the activities, gross motor, speech, psychosocial, other issues. So failure to thrive does not mean necessarily that this patient have developmental delay. So we can see a short infant, but he's an intelligent, doing everything. Gross motor, okay. Fine motor, okay. Speak at the proper time, even earlier, and have a good psychosocial development. However, he is short. It doesn't matter. This is a different area. This is the failure to thrive. Delayed speech usually diagnosed at the first year of life. The answer is no. When we consider the infant has delayed speech, when there is no wording till the age of 18 months. So we cannot diagnose. There is no place for delayed speech in the first year of life. Remember, delayed speech, no words till the age of 18 months. Delayed walking, does not walk till the age of 18 months. Delayed teething, no teething till 12 months of age. These are important points to know, to label these patients as a diseased one, to search for the underlying cause. Rickets leads to growth failure? No. Rickets is a problem with the gross motor development, not necessarily to be associated with gross retardation. As I told you before, the infant may gaining weight and properly increase in the height, but he has delayed sitting, delayed standing, delayed walking. So they are not synonymous to each other. Malnutrition affecting the growth and development? Yes, for sure. Because malnutrition affecting the growth, this is logic, and affecting the development. Because for the development, we need intact CNS, musculoskeletal system, good systemic environment, which are all using the nutritional stuff and nutritional elements for their best action and best function. So malnutrition is the commonest cause for growth and developmental disorders. Thank you very much.